This is Dr. Michael Tapper from Lenox Hill Hospital in New York City, reporting to you today from the American Society of Microbiology's Microbe 2016 conference, which is ongoing in Boston, Massachusetts. And I'm joined by Dr. Mark Wilcox from the University of Leeds in the United Kingdom, who is truly one of the world's authorities on the management and epidemiology of C. difficile disease. And I know you had a very excellent presentation in one of the sessions on pathogens, but you've also been well known, at least to those of us who do epidemiology, for your work on our understanding of the transmission dynamics and the epidemiology of C. difficile disease, not just in healthcare, where of course it receives a tremendous amount of attention because of outbreaks, but also because of our increasing recognition of the role of the community transmission, foodborne transmission, etc. And again, I know you had a very fine paper. I wonder if you could sort of describe some of your more recent findings about C. difficile epidemiology.
Okay, certainly. So the strange thing about C. diff as we learn more about it is that it can behave in lots of different ways and be transmitted in lots of different ways. And I think it's fair to say that for the first couple of decades when we've been studying C. diff, we've waited for C. diff to come to us, typically in hospitals, and studied what it does then. And there's been that's bred a lot of preconceptions about it must be the hospitals that are moving C. diff around, and indeed cases infecting other cases. And interestingly, when we looked at a large number of cases of C. difficile and used a very sensitive discriminatory typing method, whole genome sequencing, we found, somewhat to our surprise, that only the minority of cases could be related to a previous case, only about a fifth indeed. So 4/5 must be coming from somewhere else. So what are the alternatives? Could the organism be being carried by the individual and it's quiescent but then woken up once they're in hospital? Could it be that it's being acquired from other individuals who either have no symptoms, asymptomatic carriers, or only very transient symptoms such that they don't get tested for C. diff infection? Other alternatives include foodborne sources, infants who are known to have high colonization rates, and just the general environment, whether it's the general environment outside the hospital or inside the hospital. And we've actually got a number of studies following on from the one that resulted in the New England Journal of Medicine publication that we've just referred to. And we keep hoping that we'll find the answer to the missing 80%, but actually it's not a simple answer. We're only finding a few percent here, a few percent there. So the bottom line is that C. diff appears to be being transmitted by multiple routes. The importance of those routes varies according to whether you're in the hospital setting, in an epidemic setting, or an endemic setting, or indeed if you're in the community setting. And different strains indeed are being transmitted in different ways. So some strains are very successful and they'll spread very easily.
The hypervirulent strain, for example.
Indeed. And we find a higher linkage rate between cases with other cases when that strain is prevalent. If that strain is being controlled, then the linkage rate between cases is much, much lower. But the intriguing thing, you referred to it at the outset, Michael, is about community CDI, and we really know very little about that because we have waited for the cases to come to the hospital, study that.
Exactly.
And when we look in detail, it's a very reproducible finding in the small number of studies that have done this and looked at this situation. We find that about between 1/3 and 1/2 of patients in the community with diarrhea and C. diff toxin present, no other pathogen present, so it appears it truly is CDI. 1/3 to 1/2 of those have had no recent prescribed antibiotic. And yet That's the sine non qua absolute requirement in the hospital setting.
Or so we thought.
Or so we thought. So again, but one of our prime reasons for testing patients with diarrhea for C. diff is if they've had an antibiotic. So we may well be missing cases because that trigger is almost seen as an absolute requirement, but it may well not be. It certainly doesn't seem to be necessary in the community.
Well, I think that's an important point, because when someone reaches a hospital or they see an infectious disease consultant, the first thing they're going to say, of course, is maybe it's C. difficile. But if they're in the community and they see their local general practitioner, for example, that may be the furthest thing from their mind, and they may not order an appropriate test for C. difficile either.
Yes.
So we may be missing, we may be just seeing the tip of the iceberg and missing a great deal of the disease in settings other than the settings where we're used to looking for it, such as acute healthcare facilities.
Yeah, and even sadly in the hospital setting, we did a pan-European study which was published called Euclid, 20 countries, almost 500 hospitals across Europe. And we found that just among those 500 hospitals, there were approximately 40,000 missed cases of CDI per annum. So that's about 80 cases per hospital per year. Two main reasons why those cases are being missing relating to what we've just mentioned. One is a test was never ordered because the suspicion wasn't there. Some of that may be just down to a lack of awareness about the importance of CDI in countries where it hasn't hitherto been seen as a major problem. The other, though, is just doing a test, but it's the wrong test. So exactly. It lacks sensitivity.
Lack of access to a third generation or fourth generation assay.
Yeah, indeed. So, but that adds up to, and that's 40,000 missed cases per annum just in 500 hospitals. Well, there are probably about 6,000 hospitals across Europe. So one shudders to think, that what the size of the iceberg below the water that we may be missing.
It's a frightening phenomenon, as you think that how much effort we've made in acute care hospitals where I work to control C. difficile by antimicrobial restriction policies, by vigorous enforcement of infection control practices, and yet with all of that we may be missing a very big reservoir, and it really only seeing the patients when they become acutely ill and end up in hospital.
Yeah, and people tend to get interested in C. diff, and it appears on their radar when an outbreak, an epidemic has hit them, which again is, that's understandable, and you throw all these interventions in something exactly. of a state of panic to try and control the situation. So what that means is it's very difficult to work out what are the key interventions, which ones are unnecessary, but also those interventions that may work in your epidemic situation may not be pertinent to the endemic situation. So there's a lot of risk factors or alleged risk factors which are reported in association with these epidemics and outbreaks, which may actually be spurious, because it's very easy to say, oh, it's because of that antibiotic, but it may only be that antibiotic in that particular scenario, as opposed to the antibiotic per se being the risk factor.
Thank you. That's a fascinating update on a very challenging story in healthcare everywhere, not just in the hospital, but in the community as well. Thank you for your time, Dr. Wilcox.
Thank you.